Our PGY-2s are excited to present their research this morning. Quick reminder of what this research overview is. So these are projects that have been developed with the PGY-2s and their mentors. They are in development stages. So this is the perfect time for them to kind of give you guys an outline of their projects. Most of them have not been actually started yet. So it's also a perfect time for people to chime in. We've got so many smart research and clinical brains in the audience with a lot of experience. So if there's a project that you feel like you have something to add, questions to ask, feedback from stuff you've done in the past, I know our PGY-2 class would really appreciate all of that awesome feedback. We are slim-ish on time, so we're going to try to keep presentations to about 3 to 5 minutes, and then time permitting, we should have time for at least one question, maybe two, kind of depending on how the clock's going. But if people have bigger feedback, please reach out to me, Amy, Laura Cooney, Caroline, or the PGY-2s directly, because I know this feedback has been really instrumental in the past. So we really appreciate everybody's brains and help with these projects. So to get us started, yeah, I'm finding it. There we go. All right. And our Knights team, thank you for being here. They're going to go first. So our first presenter is Raiven here. Oh, she's not here yet. All right. That's okay. Olivia's going to go first. All right, perfect. So Dr. Olivia Johnson is going to present her Improving Provider Counseling in Obese Obstetric Patients, which is a QI project.
Hi, good morning, everyone. Can you guys hear me okay? Okay, sounds good. Do I advance with the clicker or the? Okay. Well, the name of my QI project is Improving Provider Counseling in Obese Obstetric Patients. And my mentor is Dr. Laura Hanks. Thank you for graciously agreeing to help me with this. So just for some background, obesity has increased substantially among women of reproductive age in the last 20 years. You can see on the right-hand side of the screen, there's two maps that show data from the CDC. It's self-reported data on the rates of obesity across the different states, across the United States. So this top graph from 2012, Wisconsin's in the about 25 to 30% range as far as self-reported obesity rates. And then in 2022, most recently, 35 to 40%. As we all know, kind of from data and also anecdotally, women with obesity are at higher risk for failure of labor to progress, higher risk of operative vaginal deliveries, and also for C-sections. So my goal when coming up with a QI project was to try to assess and improve providers' comfortability when counseling patients with obesity. And I would like to implement an EPIC SMART phrase that can be used in the prenatal period for providers as a guide to help guide those conversations, an EPIC SMART phrase that can also be used at the time of induction of labor as well. So my population will be a survey of OB providers within ASOG, including physicians. There's 21 providers who provide obstetric care in the ASOG division, nurse practitioners and physician assistants, about 11 of those, and then the certified nurse midwives, about 11 providers as well. You may notice that we left off the MFM division. We did that intentionally because the MFMs seem to have a lot more experience and practice with counseling this population of patients. And we wanted to get a general sense of kind of how the generalist population feels about their comfortability in counseling this specific population. So our aim is to understand providers' comfort level, counseling patients with a BMI greater than 40, with the intention of trying to increase providers' comfortability in providing this counseling once we've instituted an EPIC SMART phrase. Our plan will be a pre-intervention survey sent to all providers by email, and then looking at comfortability levels at 6 and 12 months after the intervention has been implemented, and it will be created and shared with all providers on EPIC and circulated via email. So our goal and my goal is to help improve all providers' comfort when we're educating and counseling pregnant women with obesity on their expectations for labor and delivery, including the different induction methods we have to offer, timeline, risk of cesarean section, and their overall risks of morbidity and mortality. For methods, I'll create a survey in the Google Forms platform to help assess providers' comfort level. When we do this counseling, the responses will be graded using a 5-point Likert scale. We'll use the same survey before the proposed intervention, after 6 months, and then after 12 months or 1 year. And then we'll synthesize the data reported in a series of graphs and trend providers' comfort level over time for each of our survey questions, with the hypothesis that after we implement a smart phrase that can help guide conversations, and the more practice that providers have with using it, that their comfort level will increase. And just for everyone's knowledge, this was an IRB exempt QI project. And these are my sources.
Anybody have any questions or feedback for Dr. Johnson? Yeah, Abby.
So using a literature review on finding kind of the most up-to-date research and data that can help to guide providers in their counseling, providing kind of a framework for motivational interviewing as well, and trying to set it up so that the smart phrase will help to guide the provider in, number one, asking maybe what terms are triggering for the patient, or trying to assess the patient's comfortability with this conversation, just in order to try to have the most effective and efficient conversation. I think there's a lot of fat shaming that's talked about in social media, and I guess that's part of the reason I want to develop a guide for providers to follow, so that we can have really respectful but also beneficial conversations for our patients. Yeah, do you mean kind of like medical assistants, nursing staff? Yeah, I think that's a fantastic idea. It didn't cross my mind, but I think it's a great area for potential expansion. Yeah. Mhm. Yeah, absolutely. I think that's a great piece of feedback. Thank you.
Awesome, thank you. Raven, we are going to backtrack for you. I know our nights team has been working hard to be here. So we have Dr. Raiven Owusu. She is presenting on staple self-removal in gynonc patients undergoing exploratory laparotomy.
Thank you. Wait, sorry.
Mouse.
Yeah. Okay. Okay.
So we're doing a QI project. This kind of study came to be, or we kind of thought about doing this when I was on my onc rotation during intern year, kind of seeing a lot of patients that would actually ask us if it would be possible for them to remove their staples at home themselves, or people who had like family members that were in medicine and felt comfortable doing it, asking if that was a possibility, keeping in mind that a lot of our patients have to travel sometimes pretty far to receive like their gyn-onc care. And so providing like an opportunity for them to not have to make that travel for a staple removal appointment. And so that's kind of where we got the idea to do this QI project, to kind of assess for like, one, kind of is this feasible, but also to what are patients like satisfaction with doing this QI study, or like having this experience. And is this something that we can like implement going forward in the future as an option for patients that do live kind of farther away and are receiving their care here with us at UW? And so kind of our QI framework is looking at this. We're using this to determine how we're going to do our study. So define, measure, analyze, improve, and control. From like a defined standpoint, talking about how staple closure is a common closure method for surgical incisions. It's pretty much what we use for all of our XLAPs that we do on our gyn-onc rotations. And so we have lots of patients that have staple closures. Talking about how, as I was alluding to earlier, a lot of patients, this is another barrier to care for them, having to come all the way back for another appointment to remove the staple, and then having to come back a few days later just to have like their post-op appointment. And so that's more like having transportation to get there, having to pay for like gas, or however they're gonna like whatever mode of transportation they're going to use to get there. If they have to have like a caregiver, give them a ride there, like finding somebody to take them to their appointment, it just like provides like more barriers to accessing their care. And so we kind of identified that as being a problem. And then looking at the fact that we have, especially like after like the COVID pandemic started in 2020, a lot of like home interventions that were studied. So looking at people doing like self-Foley removal at home, or like suture removals at home. And we have published studies that have shown like positive results with these implementations. And so seeing like a real opportunity here with allowing patients to potentially try to move their own staples at home. From a measure standpoint, we'll offer voluntary participation from participants who meet our pilot criteria for this practice change. And so we've kind of established criteria that we think are appropriate based on lots of different factors, but looking at people who we think might be good candidates for this and people who are interested in doing this. We kind of look at who's eligible based off of the information that we have going into their like pre-op appointments, and then if they are eligible, bringing it up to them and seeing what their thoughts are about it. At the time of their surgery, we would provide them with like teaching materials, so like written instructions on how to do the staple removal and kind of like warning signs for like what to look for like things that are like abnormal with incisions prior to removing their staples. Working with like the F66 nurses to help provide teaching for them, so showing them on like a little model exactly like how to use the staple removal device to take the staples out, and then also giving them access to like a online, like a video via like YouTube, showing them the steps again, and also showing them kind of like warning signs and things to look for, like actual images, so they know like visually what they're looking for. So just like kind of like really trying to provide them like a lot of like educational support to help them with this process, and making sure that they feel like comfortable and prepared to do this at home. And then before they take out the staple process, take out their staples, we'll do like a pre-removal survey, like questionnaire, which I can jump to with my next slide. Prior to taking it out, they'll have like a phone visit with an RN. So that'll kind of replace the like nurse visit they would have in person. And at that point, just like assessing for like any issues, like reporting any concerns that they have. They can take pictures of their incision to see, like if they're like, oh, I'm kind of worried about this, can you look at this and tell me if you think this is also concerning, or you think it's okay for me to take out my staples, that sort of thing. And then the incision will be able to be assessed at their post-operative appointment, which should be a couple days after removal. And then they can follow that up with like a post-staple removal questionnaire, using the Likert scale as well to assess kind of their experience with taking out their staples at home. And this is something that they can do themselves, or like a caregiver if they don't feel comfortable doing it themselves, but they have somebody in their like support group that does feel comfortable doing it. They can be the ones to do it, as long as they're there, obviously, for the training and whatnot. So from an analyzing standpoint, the kind of things that we're looking for, like with our surveys, do the patients feel like it was a feasible thing to do? Was the education that we provided sufficient? Do they feel comfortable and supported throughout this entire process? Were there barriers that we could improve? Were there any complications that would like hinder self-safe removal in the future, or like complications that would make them not want to do it again? And was overall patient satisfaction improved regarding the staple removal process in the post-op period? And then from an improvement control standpoint, we're going to evaluate this process with the first 20 participants and kind of see how that goes. We want to ensure that the care delivery barriers are being addressed and patient satisfaction are being improved with those participants, and doing like ongoing proactive hazard analyses to help with that, and then assessing for opportunities for progress and determining solutions as needed throughout that process. Happy to take any questions.
Oh. I just have a quickie. This is a great project.
Yeah.
So I'm just wondering.
Yeah. I think that's definitely something that we can consider. And if patients like don't want to, or feel like they can't do it themselves, and they have like caregivers, like family members that feel comfortable doing it, as long as they're like available to be there for like teaching and things like that.
I mean, I'm not sure that people come.
Yeah. Trying to maneuver things by yourself. Totally. I hear you.
Thanks so much.
Thank you so
Looking
much.
forward to this one. All right, so our next presenter is Dr. Alma Farooque. She is presenting Understanding OBGYN Residents' Experiences with Out-of-State Abortion Treatment.
Okay, sounds good. All right. So this project might sound familiar to some of you. Maggie Williams, current PGY-4, started up this project, and I've kind of joined in and taken on my own part of it. So if it sounds familiar, that's why. I obviously don't need to tell you all why this project is important. This audience is very aware. But at the very bare minimum, abortion training is an ACGME requirement for our residency training. So it's really important that we're properly assessing the ways that we're teaching and training our residents in abortion training. Post-Dobbs, shockingly still 1/3 of residents live in very restrictive states in terms of the legality and availability of abortion services. In terms of total bans on abortions, 14 states remain completely banning abortion. That encompasses 20% of US OBGYN residents. In terms of states that have 6 to 18-week bans, that encompasses 8 states and 14% of US OBGYN residents. And so in response to that, as we are familiar with, many residency programs have developed some out-of-state partnerships to provide that abortion training. So this is the most recent map kind of showing the current lay of the land in terms of abortion restrictions. This is as of July 29th of this year. So my study, our study, is a qualitative study that analyzes semi-structured interviews to explore the rotation experiences for the program that the UW OBGYN residency program has developed with UChicago in order to provide out-of-state abortion training. Our interviews are exploring the motivations to participate in the out-of-state rotation, the pros and cons to the experiences afterwards, the impact to their career, as well as moral distress and how that was impacted in terms of participating in an out-of-state rotation experience where abortion is significantly less restrictive. Our population are OBGYN residents in Wisconsin, so our visiting residents, and then the host residents in Illinois, currently at UChicago. Our recruitment goal is to have at least 20 participants thus far, at least half visiting and half host. And they must be current or at least recent graduates within the last year and have participated for at least 1 week in this rotation, either as a host or a visitor. And we are providing compensation. So our methods are pretty straightforward. We're recruiting via direct emails and then having Zoom interviews that we then transcribe. And then we're using qualitative analyses through an inductive approach that starts with observations, basically using a blank slate to analyze these interview transcripts and trying to extract themes from these transcripts and then codes that allow us to kind of do a thematic analysis and more holistically look at what commonalities are arising from the data. So this is just a quick graphic for anyone who hasn't seen qualitative analysis or how thematic analysis is done about how that inductive approach is put into play. And this is just a snapshot of NVivo, one of the most common software programs used for qualitative analysis. So the interview itself, we essentially adapted a moral injury symptom scale that is a validated questionnaire first developed during the COVID-19 pandemic in 2020 in order to assess healthcare providers in terms of their work and professional satisfaction, different feelings of guilt and shame, whether they had experienced a violation of their personal morals or values, and then professional and personal distress as it relates to their work environment. Our interview adapts questions from that, but also kind of assesses participants' motivations, logistical challenges that they might have experienced in traveling to Chicago and staying there for 3 to 4 weeks at a time, their clinical experiences, working with other residents, working in a new hospital, in a new system, and in general, how that rotation impacted their future career plans, if at all, and then the moral distress or injury that I mentioned. And so, our assumption is that residents are going to experience challenges in out-of-state partnerships, whether that's logistics or that feeling of moral injury after traveling to a state that has significantly fewer restrictions, being able to provide full spectrum, abortion care, and then coming back to a state where that's more restrictive. Obviously, the landscape has changed a little bit more in Wisconsin, where we are kind of back to our pre-Dobbs landscape in terms of what we can provide. So it'll also be interesting comparing kind of the first wave of residents who really participated in this partnership immediately post-Dobbs versus this year. And the current project status, we now have 13 completed interviews. Thank you, Dr. Tamkis. And that would be 9 from Wisconsin and 4 from Illinois. Some emerging themes are kind of consistent with what I mentioned previously in terms of really positive experiences in terms of the clinical and surgical training that our residents are experiencing, doing higher gestational age D&Es, providing a lot more of the patient counseling in Illinois that they aren't necessarily responsible for when we do our Planned Parenthood rotations here in Madison. And having the moral satisfaction of really being able to provide every possible option to patients, and knowing that those interventions can be done in a much more expeditious manner. And then drawbacks, as mentioned previously, integrating into a new program, the logistical challenges of being away from home, away from family, pets, kids, and then the disruption to personal life. We definitely saw more themes of moral distress in the first wave of interviews thus far for the residents who were traveling in the immediate post-Dobbs era to Chicago, in terms of really, finding satisfaction, being able to provide interventions to patients without being limited by the legal landscape. And definitely impact on future practice. A lot of our residents were already planning to be abortion providers, and this experience, this out-of-state rotation, has really cemented that for a lot of our residents and allowed them to feel more comfortable offering abortion services at higher gestational ages. So we're planning to continue recruitment through the end of this year at the least. And then I've just listed a few challenges here, including our partnership with UChicago and just kind of some challenges in continuing to recruit participants and interviewees from their program, and that's more from an IRB standpoint. And then some biases in our data that I should acknowledge: our retrospective bias when we interview residents kind of far out from their rotation experience, and then social desirability bias because myself, Maggie Williams, Alex Andes have done a large number of these interviews, and we're co-residents, and therefore that can introduce some bias as well. This is just a thank you to current and prior research team members. Yeah, that's a good question. I think that would definitely add a lot more depth and kind of geographic context to the states that are still really experiencing a lot of these post-Dobbs after effects. We haven't expanded in that sense. We've really been taking advantage of Dr. Cutler's connection to UChicago and of course our rotation being established there just to start out with this project. Yeah. So we really haven't done formal thematic analysis quite yet until we meet our minimum recruitment goal of 20, but hopefully, yes. These interviews are roughly like 10 to 15 minutes in length and do seem to have some pretty commonly arising themes so far. So I do think that that's a possibility.
All right, our next presenter is Dr. Maria Camila Ochoa, and she is presenting on optimization of contraception counseling in the pregnant and postpartum period.
Excuse me. So for this project that I'm working on with Dr. Simpene, for a little bit of background, this is postpartum contraceptive counseling specifically. In general, patient-centered counseling is endorsed by ACOG and has been applied to creation of contraceptive counseling tools, but mostly outside of pregnancy. And so far there hasn't really been any specific tool to the postpartum period. We also know that respectful, equitable, and satisfactory contraceptive counseling is important to optimize both maternal and child health, can decrease to or lead to decreased morbidity from short interval pregnancies and other obstetric related issues, and also empowers patients to achieve reproductive freedom and autonomy. And then in our institution, it's unknown whether our diverse patient population is receiving equitable and satisfactory contraceptive counseling, specifically in the postpartum period. And then there's some anecdotal feedback and individual patient feedback that suggests that there is an opportunity for improvement. So this study is a quality improvement project that we're doing the plan, do, study, act cycles, and we're using survey data that was collected anonymously to guide the need for change. So our population is all birthing patients at Meritor. The intervention was a grand rounds by Dr. Sampene, Dr. Adams, Dr. Berghong, and Anastasia Joherty, midwife, back in August a year ago, talking about optimizing contraceptive counseling. And then in addition to this, a contraceptive counseling tool and a questionnaire were created for use in the office, starting at 28 weeks and distributed to 7 out of all providing groups at Meritor who agreed to use the intervention. The idea is the outcome to look is patient satisfaction. And sorry, this is a little outdated. We're working on kind of the survey response categorization, but whether it's a positive survey response is like a net response or negative or needing improvement. So other secondary outcomes are the method of contraception chosen. So more specifically about the intervention that we did, the contraceptive counseling tool that was distributed to clinics to start being handed out at 28 weeks is modeled after the one key question, patient-centered contraceptive counseling, and it's adapted for unique considerations for performing counseling antenatally. So such as things of like how soon you want to get pregnant again and breastfeeding and things like that. I have a later slide where we can see the tool. So it's intended to use at 28 weeks or potentially afterwards. And then a questionnaire is actually handed to the patients with a thought to give with the MAs, like when they give their other screens initially, to discuss whether they have thought about contraceptive counsel or contraception in the postpartum period, and if they're willing to discuss it at this visit or have any other initial thoughts and kind of reflect on what needs and things are important to them specifically. An educational program also took place to introduce this tool to providers who agreed to use it. And an example of kind of like feedback that was also given from the initial kind of thoughts were that patients were reporting repetitive badgering to make contraceptive choices, like for example, like in triage when they show up and get asked again what choice they have or have they thought about it. So this, at the time of the grand rounds last year, providers were encouraged to look at the chart and document the type of contraception if it had been discussed and to look it up rather than repeatedly asking the patient. For the actual survey itself that was distributed to patients, it was an anonymous survey given by lactation consultants when they were in to see postpartum patients. And again, from all postpartum or all delivering groups at Meritor. Things that were asked were things such as demographic, insurance status, preferred language. They could specify which prenatal care provider they had, which I've listed here. All the providers that deliver at Meritor. And then specifically when asked about their care during pregnancy and after, so both in office or in triage on admission to the hospital, asking about the number of times they were asked about contraception, if the timing of the first ask was like too early or too late or just right, whether they were asked in OB triage about contraception. Then it also lets them state their choice of contraception or if they're undecided or just declining contraception. And then if they felt respected from their provider about their choice, and if they felt any disrespect based on race, gender, or sexual orientation. And then there was a free box for kind of additional comments that patients could write out. So for our hypothesis and goals, our goal was to improve patient satisfaction with the contraceptive counseling experience as determined by positive survey responses. And we hypothesize that a patient-centered standardized contraceptive tool will improve patient satisfaction with this. Another goal that we had was to examine satisfaction under an equity lens. And so we hypothesized that the rates may differ based on race, ethnicity, gender, sexual orientation, primary language, age, or insurance type. More specifically for methods, so we have 203 surveys from postpartum patients in the pre-intervention period. And then after this intervention was done in August, surveys have been collected every month. with goal about 20 per month for at least a year. Like I mentioned before, these surveys are anonymous and were administered by lactation consultants when they would go in to see patients postpartum. And we collected surveys from all providing groups, including those that decided to opt out of the intervention. And again, survey responses will be determined either as positive or needing improvement based on some criteria that I'll show shortly. And then we have a biostatistician helping us with data analysis in the future. So I apologize, this slide's a little outdated, but this is kind of talking about for our survey, what we are using for criteria. So the positive response criteria must have like all of these responses so that they were asked like just at the right time, just right amount of time of asking, that they felt completely respected by the provider, they were not treated differently. And then the comments could either be a positive comment, neutral, or none. And then for the second category, instead of having negative and mixed, we're discussing just having a general category that needs improvement. So basically any response that doesn't meet a criteria for a fully positive survey response. And as far as like data analysis, so far, we have only looked at the pre-intervention data at this point and are kind of determining kind of categorize all the surveys as positive or negative versus like needing improvement. And based on that, can start comparing to the data has been collected after the intervention to see kind of how patients have responded and how like providers have adapted to this intervention here. And then really quickly, I just included just like snapshots of what the tools look like. So this is the, in the center, I have the questionnaire that's asking patients to reflect on their preferences and what they've thought about for themselves and what is the best choice for them. And then on the left and right, I have like the handout that just provides information about contraception, specifically to the postpartum period. So talking about breast or chest feeding, birth control, talking about sterilization, and then after delivery, like timing of starting these things. And then there's also like charts that are attached. So these are all handed out to patients to review either on their own or with their provider. I don't think we asked like specifically like that specific question. I think we kind of just, we have probably the general demographics so people can talk about their sexual orientation and kind of things like that, and other like free comments if they want to leave specific free comments as well, but not a specific question for that.
So for example, like trying to track a short term. And what we're gonna do. Where we would maybe raise a level. The adult person. So using that a little bit. All right, so next is Dr. Emily Chiu, and she is presenting the predictive value of GATA2 in serous endometrial cancer.
I don't like.
You are?
No.
Oh, you are in the spotlight.
Hi, okay. So why do we care about endometrial cancer at all? So this is grabbed from the SEER data. I think it's up to 2000, and the data is from up to 2021. About 3% of all new cancer cases are endometrial cancer. There is luckily a pretty high survival. Can you guys see this? Yes, okay, good. High survival rate, about 80%. However, the incidence is increasing with time. The specific subtype of endometrial cancer that I'll be talking about is serous, this is the wrong slide set, endometrial cancer, which is about 10% of endometrial cancers. It's slightly more aggressive and therefore it's generally treated with adjuvant chemotherapy in addition to radiotherapy. There is a new classification of endometrial cancer using kind of more molecular-based classification, including MMR, which is polls and P53, and that just kind of subtypes of whether or not they get adjuvant therapy or not. And so in addition to this, we looked at whether or not GATA2 could be used as a biomarker of whether or not to offer adjuvant chemotherapy. And a lot of people are like, what the hell is GATA2? Sorry. And it's a transcription factor that is generally expressed in hematopoietic stem cells, but has been found to be associated with endometrial cancer. In our study design, we used a retrospective cohort study. We specifically looked at patients who were diagnosed with endometrial cancer with tissue that was stored at the UW pathology core, and they had to have documented follow-up. So looking at this, just our hypothesis and specific aims, we looked at whether or not using the UW the pathology data bank, whether we can determine association between GATA2 expression levels with recurrence, with our hypothesis being that GATA2 high tumors have a lower recurrence rate than GATA2 low tumors. And then we also look to see if we can determine if adjuvant chemotherapy in low stage serous endometrial cancers prevents recurrence. So our prediction for this was that patients with GATA2 high tumors that do not receive adjuvant chemotherapy have the same recurrence rate as patients that do receive adjuvant chemotherapy, because that's our current recommendation, that we give patients with serous endometrial cancer adjuvant chemotherapy. So doing this, basically, luckily, pathology has this great bank of tissue, and they have this great searching system that can search serous endometrial cancer. So using their biobank and their searching core, we were able to determine patient IDs with serous endometrial cancer and determine whether those patients with serous uterine cancer receive adjuvant chemotherapy or not, and then also the recurrence rate and follow-up rate for them. So in conclusion, this project hopefully will incorporate GATA2 staining into this molecular kind of like determining whether or not they need adjuvant therapy. So yeah.
Questions, comments? I think this is really timely as we're, the changing landscape of endometrial cancer and trying to figure out, if different molecular subtypes need different things. So kudos to you and Dr. Barla. It's very timely. Just get my commentary. Awesome. All right, guys, we have two more. All right, so our next presenter is Dr. Nicolette Codispoti, and she is presenting on vaginal estrogen and breast cancer APP prescribing patterns. It's a tongue twister. It is the tongue twister.
Hello, everyone. So just a little bit of background, as most of you probably know, but hormonal therapy for breast cancer typically includes SERMs like tamoxifen, as well as aromatase inhibitors like letrozole that lead to symptoms associated with menopause due to decreasing the estrogen state for these patients. And due to this, a lot of patients with breast cancer or surviving from breast cancer have symptoms of vulvovaginal atrophy, such as dryness or dyspareunia or pain with sex. We know that hormone receptor positivity can influence decisions on whether to prescribe these medications to these patients, as well as the safety of them, especially in the setting of concern for recurrence, although data so far has indicated safety in these patient populations despite hormone sensitivity in these tumors. And specifically, APPs do a lot of our survivorship care, which is why that was our target for this study specifically. So in terms of our population, we are going to do a national survey of APPs at NCI, or National Cancer Institute designated cancer centers, who take care of specifically breast cancer survivors. And our survey is really going to elicit what these APPs feel about in terms of their comfort and prescribing patterns of vaginal estrogen for patients with breast cancer and experiencing these symptoms specifically. A lot of our survey data is going to basically compare their experiences prescribing vaginal estrogen, for example, to patients with hormone-sensitive breast cancer versus not, as well as other vaginal moisturizers or things to treat vulvovaginal atrophy. And our hope is to look at differences in prescribing patterns based on vaginal estrogen and the tumor's hormone status. And so in terms of identifying a substantial response rate, especially, which is a problem with every survey, we're hoping to rely on our UW Survey Center to identify this patient population and hopefully get an adequate response rate to be able to analyze, and that there's no historical data to calculate any meaningful power calculation. So as discussed, the UW Survey Center will help us identify appropriate survey participants after we are able to identify which APPs are taking care of these breast cancer patients at NCI institutions. And then we will develop the survey and use their resources to disseminate the survey nationally and then collect responses. The basic demographic data will be provided by the UW Survey Center, and then we will also look at the survey responses, whether on the Likert scale or qualitative analysis that is extracted from some of the open-ended questions. Our hypothesis for this study is that APPs are less comfortable prescribing vaginal estrogen to women with hormone receptor positive breast cancer, despite the evidence suggesting that this is safe in this patient population. So in terms of our specific aims for this project, we're going to look at how APPs practice using vaginal estrogen for the treatment of vulvovaginal atrophy in this patient population, regardless of tumor status, as well as understand what patient symptoms may influence prescribing vaginal estrogen for vulvovaginal atrophy, especially whether it's like pain with sex, vaginal dryness, vaginal bleeding, things that may potentially push them to prescribing vaginal estrogen over not. Looking to see if their prescribing patterns differ based on what adjuvant therapy that they're on. So whether that's tamoxifen or aromatase inhibitors or any of the other ways we basically reduce risk of recurrence in this patient population. And then look to see if whether physician oversight or other safety determinations influence their ability to prescribe vaginal estrogen in this patient population and whether they do so. I'm happy to take any questions. So we're using the NCI database just to look at the cancer centers in the country that are NCI designated, and then actually identify the breast cancer centers that have APPs to be able to then be able to email them.
And we're doing community NCI centers as well, so that we get a good sample of academic and community-based practice.